Hello everyone, I'm Vadim Koshkin here with GU Oncology Now, and with me today I have a man who needs no introduction, Dr. Tom Powles, but I'll let him introduce himself in his role.
I do need an introduction. I'm Tom Powles, I'm an oncologist in London.
Great. And so today we're going to be talking about one of the abstracts at this year's ASCO conference that Dr. Powles presented, and this is concerning the JAVELIN Bladder 100 trial, and specifically the new Q-TWiST analysis. But I was thinking we would start with just maybe, again, for our audience, just a quick summary of the JAVELIN Bladder 100 study and the results.
So the JAVELIN Bladder 100 study has become, I guess, the standard of care in frontline urothelial cancer. And that's largely driven by the fact that it looks like maintenance of avelumab sequenced directly after chemotherapy in those patients whose cancer is not progressing is associated with a 25% reduction in the risk of death. And the other approaches we've tried, second-line immune therapy is probably too late for many patients, they never get there. Frontline immune chemo combos haven't panned out, we're not quite sure why. And so this sequencing with maintenance of avelumab directly after chemotherapy is associated with this kind of 25% survival benefit. It's also quite well tolerated. There are grade 3 or 4 adverse events, of course, but actually quite well tolerated, 10% steroid use, 10% discontinuation. And there's also been quality of life data. The quality of life data is, I think, quite difficult to interpret. It shows no real difference between the two, but inevitably, clearly if you're coming every 2 weeks and there's a 10% chance of discontinuation, for those patients who had to discontinue because of symptomatic toxicity, there probably was some detriment in quality of life. The Q-TWiST analysis that you talked about, that's a different way of looking at things. So
sort of combines the two, right? The efficacy and the toxicity, or the quality of life assessment.
And it brings the quality of life in as well, though it's sort of indirectly. And the principle of that analysis is that essentially you can look at from the case report forms, you can look at the duration patients have grade 3 or 4 toxicity, which by the way is quite a lot, and it's a shortcoming because you're ignoring grade 2 and grade 1. But we think if you grade 3, and of course not all toxicity is not symptomatic, so there's a problem there too. But for the period when those patients are actually having grade 3 or 4 toxicity, you can create a sort of an area under the curve for that. You can look at that time, and you can subtract that from the progression-free survival time. And so what you're left with is what we call as REL, and that's the period of progression-free survival, but subtracting that period of progression-free survival with significant toxicity. And for maintenance of avelumab, that is a larger area than for placebo because it's relatively well tolerated. And you can see there are more 3 or 4 adverse events, but that's offset by the longer PFS. And so that's the basis of what we did.
So overall, even though, yes, of course, in the avelumab arm relative to the best supportive care arm, there may be more adverse events, but that's, again, kind of balanced out by the survival benefit.
Yeah.
So, that's a very interesting analysis. What sort of motivated this, and why don't more trials do this? And will more trials do this, do you think?
There's a second part to it called Q-TWiST. And Q-TWiST actually looks at the quality of that time, because by simply removing 100% of that grade 3 or 4 adverse event time, some people come back and argue, actually, being alive with toxicity is better than the alternative, which is not being alive. So the Q part of Q-TWiST is the quality, and the question is, where does that value lie? Is it lie at 1, which is no effect on quality? That's not right. Or 0, where 100% of quality is taken away. It's probably somewhere between the two. And so we sort of Q-TWiST it looks at that analysis, and that, again, because you can guess which number you put in, and it's a shortcoming of that. Not guess, that's not fair. The folks at Pfizer actually who generated this analysis did a fantastic job in that, and I think Paul and others need to be congratulated. They all did all the hard yards and the heavy listing on this. So that Q-TWiST analysis, I think, does look intriguing. Do I prefer it to quality of life assessment, or do I prefer it to the GRAW AE assessment? The answer is no to either of those. I see it as one of 3 or 4 tools that we should be using more. What it does do is it's a very nice visual. As you can see on the 2 PFS curves, you can see the lines, you can see the toxicity more clearly, and you get a good feel for that. But I have to emphasize that key point is that it only looks at grade 3 or 4 at the moment. You could then extend it to look at grade 1 and 2, and of course, is it treatment related or is it all adverse events? And so it again comes into that area of there are many ways of analysing this. So when we analyse this data, we need to be really clear about exactly which analysis we're doing. But at the moment, it's standard to do grade 3 or 4. I don't know why more trials don't do it. It's incredibly time consuming. You've got to go through the CRFs, look at duration, all the bits and pieces, and I think that's important. And I think that it was done back in the day in some of the renal cancer trials. We did it with pazopanib versus sunitinib. Do you remember that Powles trial? I really want to
Yes,
sunitinib, pazopanib, and we did Q-TWiST there and showed that pazopanib was slightly better than sunitinib for what it's worth. And again, it's not as important as overall survival, and it's not important as a lot of other endpoints, but it does build on that. And for me, quality of life has got some shortcomings too. You know, we ask questions, some of which are less relevant than others, and we ask multiple different questions, and then in the end we often show that one drug's no worse than another, although you would have thought that that may not be the case. So my preference would be to look at this whole area, quality of life, patient-reported outcomes, TWiST, Q-TWiST, maybe even using, I don't know, wearable devices to look at quality of life in the future.
Yeah, and you feel it's important to do that in future trials as well?
Yeah, I do, but I'm not convinced that asking hundreds of quality of life questionnaires every 2 months, 3 different questions, 100 questions. I think patients get fatigued, and I think they answer the first 5 or 6 questions, and then when they're on question 72, they're just ticking boxes. I do the same in my life quite a lot. My attention span is incredibly short. I should take it seriously probably, but I don't answer quality of life questionnaires on these studies. Obviously, that's important to say. I think that we need to be more focused on the relevant question, and there's some work going on in that regard as well. I think if you ask 5 discriminatory questions, or you have a wearable device looking at step count or sleeping patterns, that may turn out to be more useful than asking these long list of different questions, some of which are relevant, some of which less so.
Yeah. Well, JAVELIN Bladder 100 has been such a pivotal trial, right? And we've done many analysis on it that really suggested over and over the benefit of maintenance of avelumab in this population. Now, this is yet another analysis suggesting this. But at this conference, and at prior conferences, with the EV pembrolizumab data being presented, what do you see as the role of maintenance of avelumab?
So I think that's a really, it's going to be a really important question. As it currently stands, the EV pembro data looks robust, but small.
Yeah.
The confidence intervals remain wide. I think the FDA approval is the right thing to do. Because patients will want this, but I don't think it's definitively beaten chemotherapy or chemotherapy in avelumab. It's not going to be possible to directly compare the randomized phase 3 trial of EV pembro versus chemotherapy because it started before maintenance of avelumab was the standard of care. Some patients will get it, some patients won't.
And most won't probably in EV302.
Yeah, but then we don't know how many patients really get. There's a big question globally. How many patients do get? Because it's an analogy, I guess, is that it's like a running race, a 4-lap running race, and the EV pembro starts from the beginning. The same with Danube and 361 and the other trials, and your maintenance of avelumab starts 2 laps in. And so it would be an unfair comparison to then say, well, what happened at the end?
Absolutely.
Now, because there's a great deal of, and the other thing is there's a great deal of selection also, and that selection is important because the avelumab study, we don't include those with progression of disease, and we know those patients do worse. And so the fact that it's a different patient population and the study starting at a different time makes these indirect comparisons difficult, impossible, and probably counterproductive. Now, maintenance of avelumab's got a 25% survival advantage. It's probably the proportion of patients that get maintenance of avelumab, I think, is probably somewhere between 30 and 50%. I don't think it's 70%. I don't think it's 10%. And real-world data suggests it's about 20. I think in clinical trials you'd probably get up to 40 or 50. But we know a lot of patients don't get there. A lot of patients progress, and there's complications around that. Other complications, some patients having had chemotherapy, then don't want to zoom on and get some time off treatment. And that is the winners. That comes, sometimes the CR patients come in and say, I've done really well. It's a complicated issue about who gets there. But clearly, if EV pembro comes in with a significant survival signal for all comers in that 0.75 area, then patients
Yeah.
will say, why would I wouldn't want to go through that chemotherapy period to then,
yeah.
you know, then take, because I might not get there. That's important. If it's greater than 0.75, then there's going to be a discussion. And then the other issue is around response. If chemotherapy response is less good than EV, and EV is much better at response, then patients are going to say, I've got a better chance of getting control of the disease, and then a better chance of getting immunotherapy early on with EV Pembro. Whereas with chemotherapy, a lower response rate, progression of disease, second-line immunotherapy is less attractive. And because we can't select those patients that are currently progressing, that's going to be a problem. So firstly, cross-trial comparisons I think we should avoid. I think these indirect comparisons that we see at the moment, I'm not attracted to. I think as it stands, the EV Pembro data is provocative and immature and small. I think the randomized trial will come out. I don't think we're going to make direct comparisons, but we will be able to look at if we get frontline survival benefit for the first time in we've never had a frontline survival benefit in a randomized trial before. If we can achieve that, then I think it will change practice.
Absolutely.
In the world. I know that practice has changed in the US, but that would be a global change.
Yeah.
And of course, there's this cisplatin eligible population as well. I feel like I'm talking too much.
No, just the right amount. And I love that we also got an analogy out of Dr. Powles with the four lap race. I always love those.
Yes, I apologize for that as well.
Well, Dr. Powles, congratulations on the great data, and thank you again.
Well, thank you for interviewing me.